Hello everyone, welcome back. In this video we will be learning about variables in mechanical ventilation which are fundamental for understanding the ventilatory waveforms and the modes of ventilation. To understand variables, we need to appreciate that respiration is a dynamic process in which pressure, volume and flow are functions of time. In other words, they change over time. These changing entities in the ventilator are called variables. Let's begin by analyzing this waveform generated by mechanical ventilator. The waveform on the left is pressure time scalar, and on the left is flow time scalar. Mechanically generated breath has one cycle of positive breath or inspiration, and one negative or expiration. There are four distinct points in breathing, namely, beginning of inspiration, end of inspiration, beginning of expiration and end of expiration. As you can see, the pressure and the flow continuously changes during different phases of the breathing. Now let's get back to the variables. There are two kinds of variables, control variables and phase variables. The control variable is the parameter which the ventilator uses as the feedback signal for controlling inspiration. Pressure, flow and volume are all possible control variables, but conventionally only pressure and volume are used. Control variables in mechanical ventilation are independent parameters which are targeted by the ventilator mechanism, and upon which all other variables are dependent. Phase variables in mechanical ventilation are parameters which control the phases of a mechanical breath, that is, starting and ending inspiration and expiration. A mechanical breath has four distinct phases, each of which has a governing variable which determines how that phase proceeds. For the ease, I will use the pressure time scalar for explaining the phases of mechanical breath. The four phases are initiation phase controlled by the trigger variable, inspiratory phase, controlled by the limit variable, cycling phase, controlled by the cycle variable, and expiratory phase, governed by the PEEP variable. The initiation phase starts at the end of expiration. At this stage, the breath is triggered or initiated either by the machine or by the patient. The trigger variable controls how this occurs. The most common trigger variable settings are time, flow, and pressure. Inspiratory phase begins once the breath is triggered and the inspiratory flow begins. This phase is defined by airflow into the patient. The limit variable controls this phase by setting limits by using either pressure, flow, or volume parameters. In other words, limit variable basically controls the extent of inspiration. Cycling phase describes the brief instant during which airflow has ceased and expiration is about to begin. This phase is controlled by the cycling variable, which determines how and when the ventilator cycles from inspiration to expiration. Typical settings include time cycling, flow cycling, and pressure cycling. Expiratory phase begins when the ventilator cycles from inspiration to expiration, during which the expiratory valve opens, and the patient exhales passively. This phase is defined by airflow out of the patient. This phase is controlled by the PEEP variable. PEEP is the pressure which remains after expiratory airflow has stopped. Trigger variables determine how a breath is started. A breath can be initiated or triggered either by the ventilator, or the patient using time, flow, and pressure. Ventilator-triggered breaths are initiated in response to a timer inside the ventilator. Such breaths are characterized as mandatory, implying that the patient has no choice in the matter. Patient-triggered breaths are termed spontaneous, assisted or supported. Spontaneous breath is completely regulated by the patient with no contribution by the ventilator. Assisted breath is initiated by the patient, but all other aspects of the breath are controlled by the ventilator. Supported breath is initiated and ended by the patient, but the breath is delivered under positive pressure by the ventilator. We will be revisiting these terms during modes of ventilation lecture with the associated wave forms to understand them more. I have mentioned that time, flow and pressure are used to trigger the breath. Let's look into how this is done, beginning with the time triggering method. When a ventilator is set to time-triggered ventilation, it will measure a period of time since the last expiration and then deliver a breath. For instance, looking at the waveforms provided, when a respiratory rate of 12 has been set, the ventilator will deliver inspiratory flow exactly every 5 seconds. Such breaths are characterized as mandatory, implying that the patient has no choice in the matter. A time-triggered mode is always mandatory. All the other trigger mechanisms permit the patient to have some control over the timing of inspiration. This was the default setting in earlier ventilator models, which did not permit the patient to take breaths beyond the set rate. Most modern ventilators allow patient triggering, and take some effort to synchronize their mandatory breaths with patient effort. The ability to provide mandatory breath by time triggering has merits, such as ensuring a guaranteed respiratory rate for patients who are insufficiently interested in breathing, providing predictable CO2 removal with a guaranteed minute volume, and eliminating wasted patient effort on triggering the ventilator. However, it also has drawbacks, including potential discomfort, higher sedation requirements, and the risk of deconditioning. The flow trigger is the most commonly used form of triggering for spontaneous modes of ventilation. It works by setting a continuous background flow of gas through the ventilator circuit even during expiration, called bias flow. During spontaneous breathing, inspiratory effort diverts some of this background flow away from the circuit to the patient. This results in decreased background flow exiting the ventilator, which is sensed by expiratory flow sensor. The difference between the flow rate sensed by inspiratory and expiratory sensors triggers an assisted breath. For instance, if the bias flow during expiration is 5 liters per minute and the patient breathes in at 3 liters per minute, the expiratory flow rate in the ventilator circuit drops by 2 liters per minute. This reduction is detected by the expiratory flow sensor. When this missing 2 liters per minute reaches a specified threshold, the ventilator triggers the inspiratory valve to open and deliver a breath. On the side note, bias flow helps to achieve peak inspiratory pressure during inspiration and positive end inspiratory pressure during expiration. So, basically in flow triggering, the patient have to generate certain flow rate from baseline to reach the threshold set by the manufacturers or the clinicians to trigger the breath. This means that, patient determines how many of breath he or she receives. In real time, ventilator will also alert you to the fact that the patient made a spontaneous respiratory effort, by coloring the waveform. The clinician sets the flow trigger sensitivity. This is typically set at 1 to 2 liters per minute below the bias flow setting, which may be programmed into the ventilator or can be adjusted by the clinician. It makes sense that the trigger be set in liters per minute as we are measuring the flow, but ventilators use different ways to set triggering. For instance, the Puritan Bennett 840 allows the user to set a flow trigger directly in liters per minute. In the example provided, the trigger is set to 3 liters per minute. Therefore, in Puritan-Bennett models, setting a lower flow trigger value, such as 1 to 2 liters per minute, represents an increase in sensitivity, meaning a lower flow is required to trigger a mechanical breath. In contrast, in the Mackay Servo I model, a lower trigger value means reduced sensitivity. The trigger is adjusted using a dial on the ventilator, with a range from -20 to +10. This range indicates sensitivity, with -20 being the least sensitive and 10 being the most sensitive. Settings between -20 and 0 represent a pressure trigger, with values indicating negative pressure in centimeters of water. For example, -20 corresponds to a pressure trigger of -20 centimeters of water. Settings between 0 and 10 represent a flow trigger, requiring a percentage of the bias flow to be deflected by the patient to trigger a breath. A setting of 0 is the least sensitive and requires a 100% flow deflection, while a setting of 10 is the most sensitive and requires only about 1% of the bias flow. Flow triggers is the most used triggering method for a lot of reasons. It is quite sensitive, that is, little patient effort is required to trigger a mechanical breath, and therefore the patient's work of breathing is not wasted on triggering the ventilation. It allows the patient to have control over their minute volume as the patient decides the rate of respiration, which prevents desynchrony. It is more comfortable because of a decreased work of breathing in triggering, increased control over ventilation and less delay in initiation. It permits a lower level of sedation because it is more comfortable. There are however some problems with flow triggering. It may be too sensitive, giving rise to auto-triggering, a form of desynchrony where non-respiratory influences on circuit flow trigger mechanical breaths. For example, the cardiac pulsation, fluid in the circuit, secretions in the airway can also trigger the ventilator. Though the patient has control over triggering, it does not guarantee a minute volume, especially in patients with a diminished or unreliable respiratory drive. Fortunately, most ventilators come with a backup mode which automatically starts a mandatory breath rate if the patient decides to be apneic for some sustained period of time. Such mode is called synchronized mandatory ventilation, which we will see in modes of ventilation video. Just like flow trigger, the pressure triggering describes a method whereby a decrease in circuit pressure is detected by the ventilator pressure sensors and interpreted as patient effort. When the patient inhales against a closed inspiratory valve, it produces a pressure drop, and in response, the ventilator delivers a mechanical breath by opening the inspiratory valve. A typical setting for a pressure trigger is 0.5 to 2 centimeters of water. Here we see the pressure trigger of -5 centimeters of water. We can also appreciate the reduction in pressure from baseline in the pressure time waveform given here. However, pressure triggering is an old-school method and is seldom used these days for the following reasons. It requires more effort to trigger the ventilator, as a change in pressure of even -1 centimeter of water requires more patient effort than a change in flow. There is a wasted respiratory effort, as no inspiratory flow is generated while the patient is inhaling against a closed inspiratory valve. If you remember, the breath is only generated when the pressure threshold is reached. This wasted effort may be counterproductive when the main objective of mechanical ventilation is to reduce the work of breathing. Despite these drawbacks, there are some scenarios which make pressure triggering useful. It can be used to decrease auto-triggering that happens with flow triggering, as pressure is not much affected by conditions that cause auto-triggering. Pressure triggering can be used to test the power of respiratory musculature, in the context of an assessment of readiness for extubation. A patient who is able to trigger the ventilator by generating a negative intrathoracic pressure of -20 cm of water is unlikely to fail extubation due to the weakness of their respiratory muscles. With flow and volume triggering, one would logically think about the volume trigger to be used in the ventilator. But it plays a minimal role in modern ventilators. This is because, under most circumstances, a modern ventilator never measures volume directly, but rather calculates it from flow over time. So, if you have your ventilator measuring flow and then converting it into volume, then surely it would be easier and more comfortable for the patient to just trigger breaths according to flow before certain volume is attained. By the same logic, any flow triggering is also technically volume triggering because some volume must change as the result of a change in flow. We can appreciate this analogy from the graphic given. In summary, volume triggering would represent a sort of pointless duplication of flow triggering. Of the existing machines, the Draeger Babylog appears to be the only ventilator which offers volume triggering as an option. Now, let's get into some new methods of triggering. The NAVA ventilator utilizes this electrical activity of the diaphragm or EDI to assist the patient's respiratory efforts in a synchronized manner. The EDI is detected by a properly positioned electrode array on a specially designed nasogastric tube. The EDI signal is then passed to the ventilator where the EDI signal is converted into the pressure. The pressure is delivered in proportion to the EDI signal and ends when the EDI signal subsides, and the pressure delivery varies with each breathing effort, and it depends on the measured electrical activity of the diaphragm. Some of the advantages highlighted by the manufacturer include improved synchrony, as NAVA doesn't not have to depend on pressure and flow which gets affected by circuit leaks, and asynchrony between patient and the ventilator. Other proposed advantages are the capability to monitor conditions such as Guillain-Barré syndrome and myasthenia gravis, rapid adjustment of pressure volume, independence from blood gas and other biochemical analyses, and a lower pressure requirement compared to conventional triggering methods. NAVA, however, has several drawbacks. It relies on intact respiratory drive mechanisms, so it's ineffective if there's bilateral phrenic nerve paralysis, medullary damage, or neuromuscular junction issues. It also depends on the accurate placement of the nasogastric sensor, which can be problematic due to tube migration or patient removal. Additionally, nasogastric access might be contraindicated in cases of trauma or surgery. Clinical evidence shows no significant improvement in outcomes compared to pressure support ventilation, and it hasn't demonstrated better results in neonates either, though no harm has been reported. Apart from the ventilatory reasons, the catheter and the ventilator are expensive. Shape signal triggering is essentially a method of predicting the next patient's inspiratory effort by observing their expiratory flow waveform. In the waveform given, the green one depicts the patient flow time curve. We need to concentrate on the expiratory part of the waveform. In shape signal triggering, a virtual flow waveform called shape signal is generated by the ventilator. This virtual signal is less than the actual flow by 0.25 liters per second and delayed by 200 to 300 milliseconds. The ventilator is triggered and the expiratory flow curve of actual and virtual waveforms intersect. Shape signal triggering is more sensitive and requires less patient effort compared to the flow trigger. However, because the shape signal method has highly sensitive triggering, auto-triggering occurs more frequently than with flow triggering. Another function of the ventilator is to limit the size of a breath. This does not mean the end of the inspiration, but rather, how big a breath can get during inspiration. The limit variable is a setting which constrain or limit the parameters of a mechanical breath like pressure, flow and volume during the inspiratory phase. Limits are set to make sure all the other variables don't go out of control in the process of achieving the control variable. Control variables are parameters that the clinicians aim to achieve during the breath. For instance, during volume control ventilation, the clinician sets a tidal volume as a control variable. The ventilator will make sure that the patient receives the set tidal volume. But doing so might also increase the pressure. Limit variable is set to make sure that the pressure is also kept in check. When the volume limit is met, the inspiratory flow ceases. Unlike the control variable or the cycling variable, multiple simultaneous limits can apply to the inspiratory phase. In other words, a limit variable is the maximum value a variable can attain during inspiration to prevent lung overdistension, and it refers to the inspiratory phase only. That is not to say that those parameters are completely ignored during the other phases of ventilation. There are still limits in place, but they fall into the territory of safety parameters or alarm limit settings. For this reason, limit variables are preferentially called target variables now. A target is what each breath cycle is aiming to achieve, that is, to deliver a breath to a preset tidal volume, preset pressure or flow. The three main limit variables in routine use are pressure, flow and volume limits. Time, of course, cannot be a limit variable, because with a time-limited breath, the breath would have to end, and that would be cycling. The limit variable of a mode of ventilation can occasionally be discerned from the squaring or plateauing of the ventilator waveform for that variable. This plateau occurs when the limit is attained. In pressure-limited ventilation, the pressure waveform gets squared, and similar squaring happens in flow and volume-limited ventilation. It does not have to be square, however, as there is no rule that says the limit has to stay the same for the whole of inspiration. If it suits you, the limit can change mid-breath, and some adaptive modes of ventilation make on-the-fly adjustments to the inspiratory limits. In a pressure-limited breath, the ventilator will allow pressure to rise during inspiration up to a certain value set by the clinician. When the set pressure is attained, any excess pressure entering the patient circuit will be released through a pressure release valve. The breath simply doesn't cycle into expiration when the limit is reached, rather the limit pressure is maintained in the lungs. Pressure control and pressure support ventilation uses pressure limiting to limit the breath. A breath is flow limited when the gas flow into the ventilator circuit reaches the predetermined set level before the end of the inspiration. Setting the flow limit requires practice with patient assessment and knowledge of physiological demands, as has implications for patient comfort. For instance, if the flow limit is set to 40 liters per minute, the ventilator will not produce a higher flow rate even if the patient makes a strong respiratory effort. This could result in decreased patient comfort and patient ventilator desynchrony as the patient's inspiratory flow demand is not met. If the flow rate is high, the peak airway pressure increases and can cause barotrauma. For reference, the typical peak inspiratory flow rate of a calmly breathing person is 30 liters per minute, and it can increase to over 200 liters per minute in an athletic individual performing heavy exercise. Modern ventilators have a theoretical maximum flow limit of about 200 liters per minute. Typical inspiratory flow limit is set at about 60 to 120 liters per minute. Flow limit is used by volume control ventilation. A volume-limited breath is delivered by the ventilator by measuring the flow of air delivered during a specific time period. This volume will be the maximum amount of gas that will be delivered to the patient during an inspiration. When the volume limit is reached, the inspiratory flow ceases with the closure of the inspiratory valve, but the expiratory phase does not begin. If the mode is time-cycled, the patient will hold their breath until the prescribed time elapses. In effect, there is a short inspiratory pause. The volume limit ensures that there is no overdistension and lung trauma, and helps maintain tight control over minute ventilation and partial pressure of carbon dioxide in arterial blood. Volume limits are employed in volume control ventilation where we find squaring of volume time waveform. Just as the ventilator needs to know when to start a breath, so it needs to know when to end it, and this is defined by the cycling variable. This setting determines which parameter is used to open the expiratory valve to end inspiration and start expiration. These parameters, called cycling variables, are an important determinant of how comfortable your patient is going to be with their mechanical breaths, as it represents another point at which they can exercise control over their tidal volume. The cycling of a mechanical ventilator breath occurs after the variable reaches the set value. Typical methods of ventilator breath cycling includes time-cycled ventilation, flow-cycled ventilation, pressure-cycled ventilation, and volume-cycled ventilation. Let's look into these cycling methods next. A breath is considered time-cycled if the inspiratory phase ends when a predetermined time has elapsed. This is usually a feature of mandatory modes of ventilation. The preset time in time cycling is determined by the respiratory rate and the inspiratory to expiratory ratio set by the clinician. For instance, when one has a respiratory rate of 20 and an inspiratory to expiratory ratio of 1:2, it is understood that, from a total 3-second breath cycle, the inspiratory phase will last 1 second. In other words, after 1 second the ventilator will terminate inspiratory flow and cycle to expiration. The advantages of time cycling of breath include the ability to achieve careful control of minute volume, which is beneficial in scenarios where precise control of partial pressure of carbon dioxide is required. Ventilation remains unaffected by changes in lung compliance or airway resistance because the timing of the breath is governed by a timer rather than being influenced by respiratory system parameters. Additionally, minute ventilation is not impacted by an unreliable respiratory drive, making this method suitable for patients who are paralyzed or deeply unconscious. However, this method also has disadvantages, which are basically the disadvantages of mandatory modes of ventilation. It is not suitable for lightly sedated or awake patients, as these individuals may become uncomfortable with a fixed, demand-independent inspiratory phase. Some breaths might need to be extended, while others might need to be shortened, which the method does not accommodate. Furthermore, there may be patient-ventilator desynchrony, particularly if the patient attempts to exhale before the cycle timer completes its run. This situation can lead to a pressure increase at the end of inspiration, either due to lung compliance reaching a point of overdistension, or as in the example below, because a spontaneously breathing patient decides to exhale before the breath cycle ends. With flow-cycled ventilation, the ventilator cycles into the expiratory phase once the flow has decreased to a predetermined value during inspiration. If we look at the flow waveform, we can appreciate that when the flow gets reduced to 20% of the peak inspiratory flow, the ventilator cycles into expiration. The flow cycling variable can be either a fixed flow value measured in liters per minute or a percentage of the peak flow rate achieved during inspiration. In some models, it is possible to set this value as an absolute number, such as 5 liters per minute. The Mackay servoa represents the flow cycling variable as a percentage of peak inspiratory flow and offers a range of settings from 1% to 70%. In contrast, the Puritan Bennett 840 provides a maximum setting of only 45%. The flow of air in the lungs is influenced by the patient's respiratory mechanics, including their effort, airway resistance, and lung compliance. As a result, the flow can vary significantly between patients and even between breaths for the same patient. Consequently, using a fixed percentage of the peak inspiratory flow as the cycling threshold can lead to considerable variability in the flow rates at which the machine transitions from inspiration to expiration. For instance, the patients with restrictive lung disease like ARDS will have poor respiratory compliance and their flow rate will drop rather quickly due to stiffness of the lung. The rapid drop will reach the cycling threshold faster, prematurely resulting in shorter inspiratory phase. Therefore, the tidal volume in the patient with restrictive lung disease is low. In contrast, the patient with emphysematous lung disease may have a very high lung compliance with greater flow with the same settings on the ventilator. So, the flow won't reach the prescribed threshold percentage, leading to prolonged breath or delayed cycling. It is therefore important to understand the lung conditions of the patient before setting the cycling threshold. Also, with a lower flow cycling threshold, the inspiratory pressure remains elevated for a more extended period as the flow takes longer time to reach the threshold for cycling from the peak value. This results in a more sustained, square waveform. Conversely, with a higher flow cycling setting, the inspiratory pressure declines more rapidly as it is easier for the flow to reach the higher cycling threshold. So, less squaring is seen with higher cycling values. Flow-cycled ventilation offers numerous benefits along with a few drawbacks. One of the primary advantages is patient comfort, as it allows patients to control their respiratory effort, unlike time-cycled methods. If a patient needs to terminate a breath and exhale, the inspiratory flow ceases, and the ventilator quickly cycles to expiration. This rapid response is a significant benefit of flow-cycled ventilation. Additionally, flow cycling is influenced by changes in lung compliance and airway resistance, which can help prevent lung overdistension. For instance, in patients with poorly compliant lungs, the flow decreases swiftly, prompting the ventilator to cycle to expiration and thus preventing pressure buildup in the lungs. However, there are some disadvantages to consider. Patients with poor lung compliance may experience inadequate tidal volumes, leading to insufficient minute volume. The overall comfort of the patient hinges on intelligent settings. Incorrectly low settings could cause uncomfortably deep and prolonged inspiration, while excessively high settings might result in double triggering due to an insufficient inspiratory time. Overall, the flow cycling needs a good understanding of patients' respiratory physiology and a good understanding of the cycling setting on the ventilator for better patient comfort and outcome. We will discuss the pressure and volume cycling briefly, as both are of historical importance and no longer used in modern ventilation. However, both pressure and volume gets big importance in control variables, which shall be discussed sometime later. Just like flow cycling, during pressure-cycled ventilation, inspiration ends when a certain user-prescribed pressure value is achieved. Pressure cycling is a feature of historical ventilator models and has become largely obsolete in the modern era of microprocessor-controlled solenoid valves. It was famous in the past because it only required nothing more than a spring-loaded diaphragm valve to act as the pressure cycling mechanism. It did have drawbacks like inadequate tidal volume if pressure threshold was set low and required higher patient effort to cycle the breath. Similarly, volume-cycled breath ends when the specified set volume has been delivered. Older models of piston ventilators were volume-cycled, or the ventilator would cycle to expiration when the piston delivered a predetermined volume. The volume will therefore remain constant, even though the characteristics of the patient's respiratory system may change. As a result, volume cycling has the propensity to generate high peak airway pressures when the lung compliance deteriorates, resulting in large incidences of pneumothorax in the past. Post-end expiratory pressure, or simply PEEP, is the final phase variable in a breath cycle and describes the baseline pressure which remains after inspiratory pressure is released, as the patient exhales. This baseline pressure keeps the alveoli open to allow for adequate oxygenation and also recruits the closed alveoli in the sick lung and improves oxygenation. The expiratory phase in modern ventilators is generally a fairly passive and unexciting time, where the only thing happening is a slow bias gas flow seeping out of the circuit via the expiratory valve. Bias flow on a ventilator refers to the continuous flow of gas that is provided to the patient, even during the expiratory phase of the breathing cycle. The bias flow ensures that a certain amount of baseline pressure remains in the circuit and lung after inspiratory pressure is released, as the patient exhales. PEEP actually governs most of the respiratory cycle, of which traditionally 66% is expiratory time and has the closest relationship to mean airway pressure out of all the phase variables. Mean airway pressure is a common pressure monitoring parameter of mechanical ventilators that is closely correlated with mean alveolar pressure and represents stresses applied to the lung parenchyma during ventilation. If the applied PEEP is too high, it can lead to overpressure of airways, and if too low, the alveoli can collapse and hamper oxygenation. The healthy lung should be ventilated with 5 to 8 cm water of PEEP. The methods of choosing the optimal PEEP in various lung pathologies are discussed elsewhere.